Hello and welcome everyone. Today's presentation is persistent AKI in critical illness. 50% of the patients experience acute kidney injury in ICUs. AKI leads to an increased morbidity and mortality, and it is linked to a higher risk of chronic kidney disease over the last decade. There is a bidirectional relationship between AKI and CKD, where CKD increases the AKI susceptibility, particularly under nephrotoxic conditions due to reduced the nephron numbers. Baseline renal function is crucial to assess the AKI risk and is included in several clinical risk scores. Now, AKI can lead to CKD by damaging the nephrons, reducing the renal functional reserve, and decreasing the glomerular filtration rate. In 2012, KDIGO defined AKI and CKD based on the duration of the kidney function impaired, that is less than 7 days for AKI, more than 90 days for CKD, and its reversibility. Kidney function impairment lasting 7 to 90 days is termed as acute kidney disease. In 2016, AKI was recognized as persistent if the serum creatinine or urine output variations per KDIGO criteria extend beyond 48 hours for the AKI onset. Reversal within 48 hours is called as transient AKI. There is a call for clear definition in the literature for persistent AKI and acute kidney disease, which are relatively new concepts. Now, before an AKI episode, what are the risk factors which can potentially make a patient more likely to develop persistent AKI? These are patient-related factors like pre-existing chronic kidney disease or reduced renal functional reserve. Patients with prior renal issues are more susceptible to more damage. Comorbidities and the clinical condition of the patient. Health conditions like diabetes, hypertension, and heart disease increase the risk of AKI. Adaptability limitations. Inherent inability of the patient's kidney to adapt to harmful conditions due to the underlying health issues can be a major problem. The next is procedure related. Nephrotoxic exposure, that is antibiotics, medications, contrast agents, these can all have nephrotoxic effect. Various intensive medical interventions like emergency surgeries can also stress the kidney. Critical illness like liver failure, cirrhosis, sepsis, other infection related complications can also add to the kidney stress and damage. Now, during an AKI episode, what are the clinical and mechanistic features of persistent AKI injury? In early diagnosis, early identification of AKI is vital for patient management. There are various baseline characteristics which can be used, that is pre-admission serum creatinine, which is measured within 365 days to 7 days before hospital admission. Admission creatinine, the first creatinine value on admission. The nadir creatinine, that is the lowest creatinine during the first 3 days of ICU stay. And estimated creatinine, this is estimated using a back estimation equation based on the assumed GFR values of age, sex, and standardized reference tables. Now, creatinine is a late marker because it is a late indicator of kidney function, only rising significantly after more than 50% of the nephrons have already been damaged. Although equations for GFR estimation are limited in critically ill patients, other methods like Jaffe equation, kinetic eGFR, and point of care GFR assessment are still being investigated. Now, creatinine urine output can be affected by non-renal factors as well, like muscle wasting, hydration status, diuretic usage, which complicate the diagnosis of AKI. Now, how do we expand the AKI definition and staging? The ADQI group suggests incorporating early kidney damage and dysfunction indicators in AKI staging. Despite their potential, new biomarkers function like furosemide stress test, ultrasound markers like renal resistive index are still underused for these purposes. Now, renal resistive index is calculated using the renal Doppler, assessing blood flow resistance within the kidney, and can predict AKI in specific settings. AKI diverse causes and manifestations cause it challenging to identify as a universal marker and approach for all cases. Now, the effectiveness of different biomarkers can vary depending on the AKI cause, the patient's population. The need for increased awareness is there because healthcare professionals need to be aware of this condition before they can make a diagnosis. Now, there are other cellular and molecular mechanisms which can be present in transient and persistent AKI. These are the adaptive and maladaptive response. Adaptive repair leads to restoration of the kidney function, and a maladaptive is unable to repair the kidney fully, so there is a decline and there is a structural change in the kidney. Now, include microvascular damage, systemic inflammation, post-fibrotic cytokine secretion, cell cycle arrest, cell senescence, pericyte activation leading to myofibroblast formation, and metabolic reprogramming of the tubular endothelial cells. Now, cell cycle arrest of the tubular endothelial cells is a very important protective mechanism to maintain the genomic stability. However, arrest can lead to senescence associated secretory phenotype, contributing to the fibrosis. There is TEC polypoidization. While this can augment kidney function through compensatory hypertrophy, it may also induce senescence, fibrosis, and CKD transition. The changes in the TEC metabolism, particularly during the sepsis-associated AKI, play a crucial role in CKD transmission. It is reprogrammed its metabolism in response to injury, similar to the immune cell adjusting the energetics and the biosynthetic needs. Now, there is a shift to aerobic glycolysis for inflammation management and oxidative phosphorylation for the renal functional recovery. These phases are crucial for managing the oxidative damage and promoting recovery. The removal of dysfunctional mitochondria through mitophagy is essential to prevent oxidative stress. Impaired macrophagy is linked to reduced renal recovery, while increased macrophagy can improve outcomes. The restoration of a functional mitochondrial pool is necessary to meet increased metabolic demands, supporting renal recovery, increased biogenesis, and it can lead to maladaptive repair and renal fibrosis. Damage to the tubule epithelial cells and the endothelial cells cause cytokine and DAMPs, contributing to the profibrotic environment. This can activate pericytes to become myofibroblasts, leading to matrix deposition, reduced capillary density, and ultimately maladaptive repair and renal fibrosis. The early metabolic shift in immune cells to glycolysis is not only crucial for immediate injury response, but also involves developing a trained immunity for the kidney, allowing to adjust responses to future insults. This concept of a biological memory in the kidney is intriguing but remains speculative. So this diagram basically shows a biphasic response to the sepsis-associated AKI, where there is an initial pro-inflammatory phase followed by a recovery phase. The initial pro-inflammatory phase is the mitophagy, and the body initiates mitophagy, a selective form of autophagy targeting damaged mitochondria, preventing the release of pro-inflammatory signals and further limiting renal damage. This process can maintain the cellular integrity by removing dysfunctional mitochondria from the cytosol. Then we have a recovery phase, that is mitochondrial biogenesis, where the mitochondria is regenerated and replenished. However, the impaired healing process can result in impaired mitophagy, where the mitophagy is dysfunctional and damaged macrophages accumulate, leading to persistent stress. And there is impaired biogenesis, where there is failure for the new mitochondria to generate, thereby again reducing the energy required for the recovery and further aggravating into a chronic kidney disease state. So next we have is an AKI episode. What is the prognosis of a persistent AKI in critically ill patients? Now, AKI can lead to increased morbidity and mortality, even leading to death. Higher progression of AKI to CKD is more likely seen as a long-term detrimental effect. Early and effective management of AKI can significantly improve patient outcomes, highlighting the critical window for therapeutic intervention to alter the disease trajectory. The concept is based on the AKI consensus, emphasizing the progression from AKI to CKD. Now, there are a lot of challenges, as we have already seen. There is an incomplete recovery despite normalizing creatinine. This returning creatinine to baseline does not guarantee full restoration of the renal function. Subclinical damage such as new onset and worsening proteinuria, arterial hypertension, and reduced RFR may persist. Now, patients with AKI who have normalized creatinine levels remain at increased risk of subsequent kidney injury and other adverse health conditions. Now, there is also a risk of persistent AKI in transplanted patients. Now, this transplant includes all transplant. Now, liver transplant, the incidence can be as high as 64. In lung, it can be as high as 69. Now, worse prognosis is seen in these patients because of the increased morbidity and mortality. Regarding specifics of the kidney transplant, there is a delayed graft functioning, An acute deterioration of the graft function post-transplant is a common thing. 30% of the kidney with decreased deceased donors and 50% after cardiac death get into this condition. This AKI impacts both short and long term of the kidney transplant. The risk factors are the comorbidities of both the donor and the recipient perioperative conditions, post-transplant exposure to nephrotoxic agents like calcineurin inhibitors and antimicrobials. Renal and non-renal outcomes in AKI post-lung transplant is linked to worse renal functions, higher mortality. In liver transplant, persistent AKI is associated with increased graft failure and poor graft survival. There is a related relationship between the length of the DGF and the risk of graft loss, particularly when the DGF extends beyond 7 days post-transplant, significantly increasing the risk of death-censored graft loss. The importance of clinical intervention is very important because it targets to minimize and prevent the duration of the DGF, reduces the risk of persistent AKI, aiming to improve transplant outcomes and patient survivals. So there is a continuum of AKI and AKD in patients with or without reduced RFR. Now, before an AKI episode, patients-related risk factors define the kidney's susceptibility. Based on this, a different intensity of exposure is required to lead to subclinical or clinical AKI. Now, the baseline critical renal function is important because of the patient-related factors. In the presence of an intact RFR, even in case of intensive and repeated potential nephrotoxic exposure, damage to the kidney may always remain subclinical. In contrast, where the RFR is lost, even in mild exposure, the kidney damage can cause significant clinical manifestations. Now, coming to the clinical approach to critically ill patients who have persistent AKI. So, we need a tailored clinical assessment. Choose clinical parameters, risk factors, biomarkers, functional tests based on the AKI setting, clinical phase, available resources and expertise of the healthcare facility. A rapid diagnosis is important, which allows a thorough review of all possible causes of AKI, caressing the reversible factors, adjusting for the therapeutic strategies. Addressing multifactorial cause is important. AKI often results in combination of patient-related and other factors. Patient-related factors might not be modifiable, but it is essential to reassess and, if possible, eliminate the exposure of nephrotoxic agent based on the current evidence. Now, a prompt intervention is required because timely recognition is vital. AKI awareness programs are required for increased understanding among the healthcare professionals. These programs should promote the use of biomarkers for kidney damage, functional tests involving all members of the healthcare team according to their specific roles. The treatment, the cause-specific treatment. Treatment should be tailored for specific cause like acute glomerulonephritis, acute renal vascular disease, which are beyond the scope of this particular video. The initial management should be based on optimizing the fluid management, supporting the hemodynamics and discontinuing the nephrotoxic agents. Medications, nephrotoxic medications are necessary, then the risk benefit should be weighed and close monitoring of the renal function is to be done. RRT should be initiated when patient's metabolic and fluid needs surpass the kidney's capacity. The choices between continuous and intermittent depends on the patient's hemodynamic stability and the health center's capabilities. Follow-up. The transition of care is important because once the patient goes out of the ICU, they must be properly followed up in the nephrology department or other ancillary departments. The monitoring and risk factors. Post-AKI care should include monitoring renal function, managing CKD complications, controlling blood pressure, patient education on medication management. Nephrological evaluation should be done to decrease mortality in these patients and to avoid dialysis. Post-discharge care is vital. A structured nephrology follow-up is mandatory. At least for 1 year should be done. Ongoing research is being done on various parameters. We'll go into the more details over here. In the ongoing research, first we have a lot of prediction models, which is machine learning. Studies of developing machine learning based prediction models for AKI. Although this effectiveness varies across different clinical settings, few models have been specifically designed or validated in critical care setting, highlighting a gap in research. Transcontinental database models predicting AKI within 48 hours of critical illness have been studied. Now, there have been controversies in the AI prediction because we need further trials and to make them applicable. Regarding the renal functional reserve, we need assessment methods which can be used at the bedside, and subclinical damage needs to be found out because creatinine is clearly not a very good marker. Intraparenchymal and renal resistive index is a very good parameter which needs further trial and should be used more often in our ICUs for renal functional assessment. The functional stress test, that is furosemide test. This test evaluates renal tubular function and predict AKI progression and the need for dialysis. It helps identify patients at higher risk progressing to AKI to CKD. Systematic review and meta-analysis indicate that the furosemide stress test utility in identifying high risk is better in early AKI stages. Variability in the study designs, dosing and timing, as well as reliance on area under the curve values may limit its applicability. The GFR measurements have advanced with transdermal sensor technology, allowing for continuous real-time GFR monitoring by measuring the plasma disappearance rate of injected GFR markers, offering a more accurate assessment of the renal function. So coming to the treatment, what are the recent advances? Currently there are no pharmacological treatments specifically which can prevent. Early research is going on for investigating a range of potential treatments, novel compounds, repurposed drugs and cell-based therapies. These therapies target oxidative stress, cellular repair, inflammation and hemodynamics. Regarding follow-up, post-AKI emphasis is the need for careful follow-up with various biomarkers like CCL14, DKK3 and renal functional tests by RFR assessment. Drugs affecting the renal angiotensin aldosterone system and sodium glucose co-transporter 2 and inhibitors are beneficial in AKI and may offer therapeutic avenues for individuals recovering from AKI. So to summarize, the future direction and the future management depends on prediction models of AKI, identifying new drugs to treat AKI, finding out new biomarkers for follow-up and early identification, use of furosemide stress test, real-time GFR monitoring and RFR assessment, because creatinine is not a very good marker. Thank you for your patience.